Morning. I'm going to be talking to you about navigating heterotaxy, advances, challenges, and future horizons in research. I hope over the next 20 minutes, we will review current heterotaxy-related research and future directions. We'll discuss challenges of conducting heterotaxy research, review existing registry opportunities, and talk a little bit about the development of local heterotaxy registries. So as I was developing this presentation, I did a literature search to try and understand the current state of heterotaxy-related research. I started with a PubMed search that included terms of heterotaxy, atrial isomerism, polysplenia, and asplenia in the title or abstract, and then I parsed down the results to just scientific manuscripts, excluding case reports, commentaries, and reviews. I also excluded any articles where the primary focus was on complex congenital heart disease, or PCD, and in which heterotaxy was just a subgroup analysis. I wanted articles that were purely focused on patients with heterotaxy. This graph shows the absolute number of scientific manuscripts that were heterotaxy focused over the last 2 decades. You'll see that there was an increase in the number of manuscripts in the early 2000s, but over the last 10 years, the amount of scientific literature generated has been relatively stagnant. But what struck me most is that in a given year, there are only about 15 to 30 scientific manuscripts devoted to this population. And while heterotaxy may be rare, the complexity and severity of this diagnosis should open up multiple avenues of investigation. So what kind of content are we generating as a community? There have been several manuscripts devoted to the genetic origins of heterotaxy, definitions and diagnosis, clinical and surgical management, and outcomes. The focus in the vast majority of these manuscripts has been on congenital heart disease and primary ciliary dyskinesia, and this should come as no surprise to any of us since these are the most prevalent diagnoses, but also carry the greatest morbidity and mortality. On the genetic side, we've learned much about the genetic underpinnings of heterotaxy and some of the embryologic pathways that are involved. We've learned more about the constellation of comorbidities that segregate into different types of heterotaxy. And with that, we've also learned that our classification systems for heterotaxy are incomplete and do only a marginal job of predicting how these features cluster. We talked a little bit about this yesterday during the cardiac features of heterotaxy talk. This was a review from Sick Kids and 114 patients with heterotaxy who underwent cross-sectional imaging to evaluate atrial appendage morphology, bronchopulmonary, and visceral organ arrangements. Among those with definable morphology, approximately 40% had classic right atrial isomerism, meaning bilateral right atrial appendages, right bronchopulmonary patterns, and asplenia, and 40% had classic left isomerism, meaning bilateral left atrial appendages, left bronchopulmonary pattern, and polysplenia. However, classic patterns of isomerism were reached in roughly 20% of patients. The flowchart here shows the percentage of time that bronchopulmonary patterns and atrial appendage morphology differed by spleen status. And so you can see that among those with asplenia, the vast majority had classic patterns for right isomerism at both the bronchopulmonary and appendage levels. However, among patients with polysplenia, only about 75 to 80% of patients had typical bronchopulmonary and appendage patterns for left isomerism. And then remarkably, there were 4 patients who had completely normal spleens, but abnormalities in bronchial and appendage morphology. This was the editorial that accompanied the analysis and highlighted the need for a new approach to classify heterotaxy. They make the point that although there are statistical associations among various cardiac and extracardiac anomalies, these are merely associations and not rules. And later in the article, they also state that the currently used classification systems do not work, but also emphasize the importance of individualized approaches to diagnosis based on a systematic segment-by-segment analysis of each part of the cardiovascular system. This is another example of how the patterns of left and right atrial isomerism break down in heterotaxy. This table comes from the ECHO textbook and was shown yesterday that most pediatric cardiology fellows use. It summarizes the various case series of heterotaxy patients that have been published in order to compare the incidence of cardiac anomalies seen in right and left atrial isomerism. You can see that certain anomalies appear to segregate well, like interrupted IVC and polysplenia, or complete atrioventricular canals and pulmonary stenosis or atresia in right atrial isomerism. But most are highly variable, and some could argue that there really isn't a consistent pattern when you look at it this way. There's also been a fair amount published on cardiac outcomes in heterotaxy. We presented many of these studies yesterday and discussed which patients are at particularly high risk of poor outcomes due to not only cardiac, but also extracardiac causes. This is a very simplified and, I admit, highly incomplete way of looking at cardiac outcomes in heterotaxy, but I do think it drives home the severity of the diagnosis and the urgency in finding novel solutions for these patients. So between 80 to 85% of patients with heterotaxy have congenital heart disease, which can come in all forms, but is usually complex and severe. Between 49 to 75% of those with heterotaxy-associated congenital heart disease will ultimately be palliated towards a single ventricle pathway. And while single ventricle heart disease is more common in right atrial isomerism, it can also be seen in left isomerism and often co-occurs with other complex features like pulmonary or systemic venous abnormalities. As a result, these patients have very high postoperative and long-term mortality. So depending on the severity of the heart disease, mortality can range from 4 to 23% in the immediate postoperative period and can be as high as 20 to 40% in the first 10 years of life. The causes of death tend to be multifactorial, but are most commonly due to the cardiac or pulmonary disease. What is particularly alarming, though, is that there has been minimal improvement in the long-term prognosis of heterotaxy over time. So these data come from Boston Children's, a cohort from 1985 to 2014. The 10-year mortality rate in this study was 40%. And while there's been some improvement from the earliest era shown in red to the latter era shown in blue, black, and green, long-term survival did not significantly improve from the 1992 cohort to the most recent 2008 cohort. These data are a bit outdated since the last birth era ended in 2014, but at least anecdotally, I think that many of us who care for patients with heterotaxy know that this group remains at very high risk of both early and long-term mortality. So where are the opportunities for heterotaxy research, and how do we start to improve outcomes for our patients? First, there is ample opportunity to improve our classification systems of clinical phenotypes. As we just saw, our current classification systems are incomplete and provide really limited information on prognosis. So novel ways of classifying these patients could help with risk stratification, screening, or even clinical and surgical management. Second, it's important to understand the relationship between these clinical phenotypes, genetics, and ultimately outcomes. This interplay between genotype and phenotype likely has significant bearing on clinical outcomes, and again, may help with screening and management. Third, we need better risk algorithms to do a better job of tailoring management strategies. We reviewed a few of the published risk models yesterday, but all were focused on cardiac anatomy, contained very little extra cardiac data, and were built using traditional risk modeling strategies. We can do better. Finally, we need to understand how multidisciplinary care can improve outcomes. And so this comes in the form of teams of physicians who are devoted to integrated heterotaxy care. But there are multiple challenges with studying heterotaxy. First, it is a rare disease. With a quoted incidence of 1 in 10,000 births, most institutions in the US will see between 10 to 25 babies with heterotaxy each year, which limits the interpretability of single center studies. Second, there is considerable heterogeneity in phenotypes and management strategies. So the complex anatomy and physiology of heterotaxy, coupled with small numbers, limits our ability to pick up on differences in outcomes across clinical traits. And then finally, there is considerable institutional variation in both surgical and clinical management, such that the findings at one center may not be generalizable to others. And these challenges all point to the limited utility of single center studies and really understanding both the presentation and the outcomes of this patient population. So what about multi-center registries? In the field of pediatric cardiology, there are several registries that contain data on patients with heterotaxy. I've listed some of them here. Each focuses on a different type of heart disease, management strategy, or type of hospital encounter, but could ultimately offer some useful information on a select group of heterotaxy patients. I'm told that there are also a few pulmonary registries, such as the one run by the PCD Foundation. But one of the goals of the HRC3 collaboration is to leverage existing registries for research. And so this group has started to work on a few of these registries to advance them. But these registries also have their limitations. First, they are usually focused on single organ systems. So the cardiology-focused registries were designed to study common cardiac surgeries or complications and contain relatively little data on extracardiac disease. Second, these registries usually do not collect detailed anatomic data, either cardiac or extracardiac. They tend to use classic groupings or cardiac diagnoses rather than systematically entering data on segmental anatomy. Third, diagnostic and management strategies are incompletely captured. So it's not always obvious which diagnoses a patient was screened for, and many of the procedural and extracardiac diagnoses come from ICD codes. Fourth, aside from the Pediatric Cardiac Genetics Consortium, few contain rich genetic data. And then finally, these registries usually follow patients for a finite amount of time, such as through hospital discharge or occasionally out to a year or two. But long-term follow-up is virtually unheard of. And so there's a clear need to improve the multi-center data that's collected on patients with heterotaxy. Ideally, these data should contain rich information on cardiac and extracardiac anatomy, genetics, screening and management, and then outcomes across multiple organ systems. There are beginning efforts underway through the HRC3 in the form of toolkits to help sites create local registries that might be ultimately merged across institutions with common data elements. I'm going to give you an example of how the Boston Children's Heterotaxy Registry was launched and review some of the lessons that we've learned in the process of getting it off the ground. When we started the registry back in 2020, we started with the vision of creating a registry from which we can learn about diagnostic and management strategies for patients with heterotaxy. We wanted this registry to be inclusive of all heterotaxy-related diagnoses, so we involved representatives from all major subspecialties that care for patients with heterotaxy. We co-developed the registry with these representatives, asking specialists to come up with questions and data elements that they wanted to see collected. And then we implemented standardized data collection methods and reviews to validate the data that was collected in order to ensure consistency and maintain quality. Finally, we used standard data elements so that we knew where and how to abstract data easily. And this helped streamline flow and improve functionality of the registry, even when we had more than one research assistant working on the registry at a time. This process did not come without multiple rounds of iteration that include feedback from stakeholders, edits to data forms and the manual of operations, and onboarding of new research assistants. But the goal was ultimately long-term sustainability and ideally scalability across institutions, which requires funding, resources, and personnel. So for the Boston Children's Heterotaxy Registry, we included all children followed in Boston from 1990 to present with a diagnosis of heterotaxy who underwent some type of cardiac intervention. Patients were identified using filer codes, which is a diagnostic coding system used in Boston and reviewed by the team for inclusion. And this registry included patients who were born locally as well as those referred by other institutions. After the initial intake, we collected information on cardiac, pulmonary, GI, and surgery, immunology, and genetic data. And we collected information on anatomy, history, screening, and diagnostic tests that were performed, and then ultimately the management at Boston Children's. After that initial intake, any subsequent imaging, diagnostic testing, and procedures were collected on follow-up forms. And then we collected information on several potential outcomes, including death, cardiac transplant, listing and receipt, final cardiac circulation, growth and enteral access surgeries. For individual surgical interventions, we also collected details on duration of mechanical ventilation, length of ICU and hospital stays, ECMO, pacemaker placement, operative or cath-based cardiac interventions, and to date, we've compiled the registry from 1990 to 2014 and are working on updating the registry over the last 10 years. There are about 260 patients in the database for whom we have a minimum of 10 years of outcomes. We're just starting to explore potential research questions, but these will likely fall in the domains of quality improvement, descriptive studies, and risk prediction or stratification. So examples of questions that we might be able to ask could be what percentage of patients undergo routine screening for malrotation, receive referrals to immunology for splenic function assessments, or undergo preoperative screening for ciliary dyskinesia. What is the prevalence of extracardiac anomalies in heterotaxy? And what are the strongest cardiac and non-cardiac predictors of long-term survival in patients with heterotaxy? I thought I'd give an example of one project that's underway where we're trying to refine the classification systems for heterotaxy using data from this registry. So rather than using the typical definitions of right and left atrial isomerism, we wanted to see whether there might be other clinical phenotypes that offer prognostic utility. So we asked the question of whether we could use unstructured machine learning algorithms to segregate the data into anatomic phenotypes. To do this, we've applied principal component analysis and hierarchical clustering models to 47 cardiac anatomic variables. And with that, we were able to identify 5 clusters of cardiac phenotypes. So cluster 1 had a predominance of right dominant atrioventricular canal defects, double outlet right ventricle, and pulmonary stenosis or atresia with TA-PVC. Cluster 2 was similar to that of cluster 1, but with left dominant AV canal defects. And these 2 clusters are what most would think of as being your kind of more typical right atrial isomerism. The remaining 3 clusters consisted of those with left-sided obstructive lesions and interrupted IVCs for cluster 3, transposition of the great arteries with pulmonary stenosis or atresia for cluster 4, and then a mixed bag of lesions with an interrupted IVC for cluster 5. And using these clusters, we looked at how often patients in each cluster were classified as asplenia or polysplenia. Interestingly, cluster 1 and 2 were more often classified as asplenia, but there were still a fair number of patients who had been labeled as polysplenia. Clusters 3 through 5 were more commonly classified as polysplenia. We also looked at the frequency of the time that patients underwent single versus biventricular heart surgery. So clusters 1 and 2 were more likely to undergo single ventricle palliation, whereas those in clusters 3 through 5 were somewhat more divided. Cluster 5 very rarely underwent single ventricle palliation. When we looked at survival, patients in clusters 4 and 5, that's shown in brown and purple, universally did well. You'll recall that cluster 4 tended to have a high predominance of transposition of the great arteries and pulmonary stenosis or atresia. And cluster 5 was patients with interrupted IVC, but other miscellaneous features. The other 3 clusters had worse survival during the early childhood years. Interestingly, when we stratified the results by the type of surgical repair or palliation that was received, we saw marked differences. So cluster 4, shown in brown, again did universally well regardless of the type of surgery, whereas clusters 3, shown in green, and cluster 5, shown in purple, did much better with biventricular repair. Almost all patients in clusters 1 and 2, those are the unbalanced canals, underwent single ventricle palliation. There were a lot of nuances as to who undergoes biventricular repair versus single ventricle palliation, but I think that these data start to point towards phenotypes where there might be a preferred surgical strategy. So where do we go next? The HRC3 is working on developing guidance for institutions to develop local heterotaxy registries. And then we've discussed some possible linkages to some of the cardiac registries to obtain more genetic data or robust follow-up. So I think the future is bright for heterotaxy research. And we hope that there will be much enthusiasm for exploring these multi-institutional collaborations. Thank you.